Welcome to EMS Research with Professor Bram, where we talk about EMS research related to paramedics and first responders. Today, we're going to be talking about paramedics finding a differential diagnosis. My name is Bram Duffy. I'm a research fellow with the Institute of Social Innovation at Fielding Graduate University. As a paramedic myself with over 20 years experience, both 911 and critical care, I do the job daily, just like many of you. I've also taught over 60 college-level classes in areas like communication, leadership, and EMS. And my own research is in the area of how paramedics communicate. So I look forward to connecting with like-minded people. So before we get started, I want to share with you that I've written 2 books on communication. The most recent book just was released called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. You can find a link to the book below. Also, for sure, hang out to the end because I want to talk to you more about it. So if you go to the resources page on my website, which is professorbram.com, you'll see a list of EMS magazines, academic journals, and things that are related to EMS, like podcasts. And so there's a bunch of resources out there to learn more about EMS-related research. But this stuff's not always accessible, and it helps if you belong to an academic institution. I bring up this list of journals and other resources so you can see some of the top players in the field of EMS research and what's out there. For example, one of the main players that helped us get our field going and is always happening is JEMS, which is the Journal of Emergency Medical Services. And I love them especially because I liked getting that magazine in my hand. And it was always around the work environment like the fire station for easy reading. And if you look on the JEMS website, you'll see some of the articles where I've actually been published with them also. But anyway, I'm a big fan of them. They just don't have a print version any longer. The other players out there that help get EMS research kind of stuff out there include EMS World, or my favorite, EMS One has a website. And they're all online resources for EMS professionals, but there is a new player coming out in July 2023 called Fully Organized. So the cool thing about them is the trade magazine in EMS that is going to come to your door and be in paper version again. So they're not a sponsor or anything, but I already purchased my subscription. I'll report back, let you know what it's like. But one of the cool things about the magazine Fully Oriented is that they accept articles and case studies from regular people. So I haven't seen their guidelines yet, but if you're interested in writing for GEMS or Fully Oriented or any other magazine, it's an incredible experience. So start out by looking at author guidelines is how to make that work. So in the Journal of Prehospital Emergency Care, a 2023 article was created by Gugiu and others for the National Registry of Emergency Medical Technicians. It was called A Proposed Theoretical Framework for Clinical Judgment in EMS. People who work in EMS use both what they know and what they see to hear and make decisions about how to help their patients. But this is complicated by the fact that they're working constantly in a changing environment. So there isn't any one way to describe everything that happens in pre-hospital care or how EMS clinicians make decisions. But the authors for this article think that it would be helpful to put together a framework to better understand these things and try to help improve EMS education, assessment, and decision-making goals. So they proposed a theoretical framework for how EMS clinicians make decisions in the pre-hospital setting that uses ideas from previous studies and applies them to EMS practices. So there's a model that these researchers put together. And I'm not showing the model because of laws that protect the distribution of stuff, but you can find it easily referenced on the NREMT website. And the visual model they share takes into account time and activity. So that would include the start of a call at dispatch through getting on scene and then actually the after scene activities as well. So they have 3 focal points that they put together for their model. And they show the way this looks in feedback loops over time. So factors like communication and leadership are factored in as well. And like environmental cues and the individual clinician, all of these things are packed into the overall model. But one of the biggest key parts are the feedback loops to be able to use as a thinking process at each stage. So one of the stages was the part where you are doing the patient assessment on scene. And so for that time, the things that the model look for include recognizing cues, analyzing cues, defining a hypothesis, generating solutions, taking action, and evaluating. The way the model that they're presenting works, it's like new information gets processed and helps reach decisions. So this works good to help think about varied and complex situations. And the process information cycle includes all of these recognition of different clues. And after you recognize a clue, taking action to resolve it. But this process is a continuously happening cycle where new cues come in and we reanalyze the situation. This is a framework for clinical judgment in EMS. It's important because it helps us understand how we make decisions in a complex environment of pre-hospital care. We know there are lots of different cues that we respond to, and we need help getting through the process to analyze information and make decisions as new information comes in. The way providers make decisions can really vary depending upon how much experience they have. So less experienced providers may rely more on things like taking one step at a time, while more experienced providers make quick but accurate decisions based on their deep understanding of the situation. Paramedics are usually the first ones to show up when there's a medical emergency. And now there's a perception out there that paramedics are like technicians and not really decision makers, especially when compared to doctors or nurses. And a lot of this comes from the fact that paramedics don't go through as many years of formal education that doctors do. And over 20 years ago, when I started out working as a paramedic, there was a real push for the paramedic level to just be responsive. So what that means is that if a person isn't breathing, then you breathe for them. There's much less concern on training why they're not breathing. And it's considered uncouth for a paramedic to form a diagnosis because that's specifically the job of the physician. And the thing is that it's always strange for me that all along I knew that as a paramedic, I have also been diagnosing, or at least working off of differential diagnosis. And we know that paramedics follow protocols, but to know what correct protocol to follow still requires them to make a differential diagnosis, to know what page to go to. As we all know, there's a big difference between asthma and CHF and allergic reaction and trauma. All these things can be the cause for difficulty breathing, but they all have different treatments related to what's going on for the cause. So let's just think about this for a minute. Yes, becoming a doctor involves years of medical school and residency, and nurses go through it with rigorous nursing programs. Paramedics do about a 2-year program, and then they're out in the field. And now I'm not saying that the knowledge that doctors and nurses gain through their extensive education isn't important. Of course it is important. But what we might not want to do is equate the length of education with the ability to make critical decisions. Paramedics have a unique set of skills, and those skills allow them to make quick assessments and take action in high pressure situations. So this other thing that we have to consider, which is experience. A paramedic who's been on the job for years, responding to emergencies day in and day out, they have a level of experience that's incredibly valuable. And they may not have spent as much time in a classroom, but they've definitely spent a lot of time in the real world dealing with the real life critical situations. And that kind of experience can teach lessons that no textbook can. So I think it's time that we start seeing paramedics for who they are, which are decision makers with this unique set of skills and expertise. And so we need to create more opportunities for continued learning and growing in the field, and more importantly, foster a culture of respect. And these practical skills are just important to be recognized. I submitted a research paper that I did to a major industry journal, and it was one of the top journals in our field. I'm not going to mention the name, but let's just say it was the top. And the research I submitted to describe the experience that paramedics go through when they're dealing with an extremely stressful moment of figuring out what's wrong with the patient. So basically, I was proposing that the time between the alarm and the time that you figure out what's wrong with the patient and get a differential diagnosis down, well, that time's super stressful. And so I was describing that, and I was talking about how paramedics form a differential diagnosis, and when they do, the stress is less severe now because, well, they've got a little bit of the handle on the situation, so to say. But this lead journal editor, who was a physician, made it really clear to me in his response that paramedics do not form a differential diagnosis. And so when I heard this, I was completely blown away. I almost fell out of my chair. I'm like, well, what does he think I do as a paramedic, right? But I wasn't in a position to argue because it's not going to help my research project get published. But what that experience did give me was an understanding of the old guard, the old way of thinking about how paramedics are just technicians. So I'd like for you to imagine that you're in charge of a paramedic team of EMT or firefighter responders. So this can be tricky because if you're the in-charge paramedic, then that person who may be the only level trained to that degree could easily feel like they're separate from the rest of the team. And having that expertise gives them insulation to feel like their job is to make decisions all by themselves without so much input. So this way of thinking can come from the roles that have been assigned within the team. And because no one might challenge their new ideas or decisions, they might believe that what they're doing is right and is always right. We talk about this as self-confirming bias, or that's what we consider it to be. And it's not always bad. Sometimes having someone make independent decisions can lead to good results, especially when the rest of the team isn't great at decision making. But if the leader starts validating themselves too much, it can lead to stress and even more complicated problems when things get tough. That's why it's really crucial to understand how paramedics think when they're out in the field. And so by doing this, we can learn about different types of thinking and avoid falling into poor decision-making cycles. And so let's imagine an emergency call comes in, an ambulance is dispatched, and there's two types of paramedics who will be leading the team. One who's fresh out of school and the other who's been in the field for like 4 years. This newbie, or the early career paramedic, doesn't have a lot of real-world experience yet. They're relying on what they learned in school, like textbook knowledge and memory tricks. So on the other hand, the seasoned pro, or the late career paramedic, has plenty of time where they've been able to put in to develop their own strategies. And they've figured out how to prioritize things intuitively and behave accordingly. A recent study from Finland by Registry in the Scandinavian Journal of Trauma, Resuscitation, and Emergency Medicine found that paramedics had a 70% accuracy rate when determining the differential diagnosis for a patient. These types of studies are difficult to weigh out because it's like comparing the diagnosis that the doctor figures out at the hospital after doing all the diagnostics. The paramedic actually did not have any of the same imaging or labs to evaluate. So we have to remember that providers only make decisions based on the information that's available to them. The other interesting discovery was mapped out in a 2016 study by a researcher at McMaster University that shows when a patient's presentation doesn't fit within the treatment protocols that are established by the paramedic medical director, the physician medical director, the paramedics of all levels of experience have difficulty with decision making. But for things that are everyday bread and butter staples of paramedic training, they are overall pretty good. A study from 2002 in the Emergency Medicine Journal showed that UK paramedics can recognize ST elevation using a 12-lead EKG. The study results were so good that they discussed how radio transmission of the EKG just wasn't really necessary to pre-alert the hospital because they felt that those results were showing that they should be able to trust the paramedic. So this journal suggests that doctors don't always need to be the ones making the hardcore decisions. And it turns out that paramedics can handle the job just fine. In a lot of cases, this really could be a game changer in terms of cost and shakeup on how things are done with pre-hospital diagnostics. Because I've been practicing as a paramedic since 1998. And this study came out in 2002. I can tell you that I feel a difference on how paramedics are trusted by physicians when it comes to 12-lead specifically. And I guess it really comes down to if the physician has positive experiences with a local EMS system and the individual providers. But this information could also play a role in discussions about how paramedics administer pre-hospital thrombolytics. We know that they can recognize different EKG changes, but just to be clear here, recognizing those changes isn't the same as diagnosing an acute MI. It's a whole lot more complex than just identifying ST elevation. So before we could say anything definitive about a paramedic's ability to diagnose a MI, we need more research, especially around the potential diagnostic errors. Of course, we have to think about things like troponin and just the current technology that's out there to help with this identification, right? But the reality is that many hospitals don't perfectly respond to these patients. So there's no one size fits all. And ensuring early thrombolytics mean that we need to hit this from both sides and optimize each step, starting from the initial symptoms. Another study we can look at in a 2006 article shown in the Prehospital Emergency Care journal. So imagine you're having trouble breathing and you call an ambulance. And on the other end of that call is a paramedic trying to figure out what's causing your distress. This study looked at how good paramedics are at diagnosing the cause of the difficulty breathing based on their ambulance call reports. The researchers went back and looked at all of the call reports from one ambulance over a year, and they compared what the paramedics recorded as the diagnosis with official diagnosis given by the doctor in the ER. They found that for patients who reported difficulty breathing, paramedics are pretty good at identifying the cause. They correctly diagnosed heart-related issues 86.4% of the time, and lung-related problems 71.4% of the time. They also had an 82.1% accuracy rate for diagnosing other diseases. So here's the kicker. When they compared paramedics' diagnosis to the doctor's diagnosis, they agreed 81.1% of the time. That's quite a high level of agreement, which shows that paramedics are generally on the ball when it comes to identifying the cause of especially breathing problems. So the next time you're in an ambulance, you can be somewhat reassured that the paramedic treating you has a good idea of what's going on. Of course, they're not perfect, but they're getting it right a significant amount of time. I think we can say that training and experience makes a real difference. So let's look at some different studies in that regard. Because a 2009 study in the Journal of Prehospital Emergency Care examined how the experience of a medic in charge of implementing procedures like IV line, intubation, and worrying about the medicines found that for every year of experience this medic had, it was associated with a 2% increase in the likelihood of the survival of the patient. An increase, 2% likelihood survival of the patient each year that they work as a paramedic. So if you've been a paramedic for 50 years, I guess you have a 100% chance of getting the patient back. That's a side joke, but that shows that experience really does matter. Similarly, in studying CPR, a 1999 study in the European Heart Journal found that paramedics with over 1 year of field experience achieved better survival rates than paramedics with less than 1 year of experience. Tuttle and Hubble in 2018 found that paramedics who had been exposed to 15 or more CPR cases across the previous 5 years were 21% more likely to deliver successful resuscitations. A 2018 study examined paramedics' experience with the consideration of CPR successes also, and they determined that the less experienced group resuscitated patients at 22.2% of the time, while the more experienced group achieved 28.9% success rate. So 22 versus 28%. In all these cases, experienced paramedics were shown to achieve better results than were their less experienced colleagues. These last three studies were the most significant for me personally because it's super interesting to be able to reflect on the fact that experienced paramedics are the true lifesavers. Today's topic on paramedic differential diagnosis was fun for me, and I look forward to your feedback. You can always listen to me here, but I want to let you know about a special opportunity if you're a paramedic student or instructor. I'm making myself available to meet live by webcam to talk to your class about the topic of EMS research. And so this is a great opportunity to learn more about how research impacts what happens in the field. So for those paramedic students or instructors out there, just reach out by filling out an inquiry form on the professorbram.com webpage. I want to also invite you to check out my latest book. This book was already rated as Amazon's newest #1 release in the emergency medicine category, which blew my mind when I saw it. I co-authored this book with 4 Arrows, who has 2 doctorates and is an expert on indigenous thinking and hypnosis. So I just want to invite you to check it out because we introduce a method for communicating with patients on the scene of an emergency that takes advantage of some of the properties found in hypnosis. And overall, the thinking that we introduce works to change the way we approach and interact with any emergency patient who's in acute distress. So the book is called Hypnotic Communication in Emergency Medical Settings for Life-Saving and Therapeutic Outcomes. You can follow a link below to find it or go to almost anywhere where books are sold to find it. If you contact me with proof of your order, I would be happy to mail you an autograph sticker that's designed to stick in the inside jacket cover. So I hope you check it out.
If, as you've said so thoroughly, that we've got to look at each individual patient as a human being who is in need. And we've got to know that when we're in need, we do look to others, no matter how self-reliant we are. if we are in a situation that we've never encountered before, that self-reliance begins to seek, is there anyone that can help me with this situation? I mean, you've used a pretty drastic example with the arm cut off, but I don't care how much skill you have. There's very few people who would be able to not say, "Oh my gosh, I need help," and then all of a sudden someone shows up
with a badge.
Yeah, and you think, well, maybe this is someone that can help. Well, you said that, and I said that, during the first hour of trauma, people are essentially in a state of what we now know is hypnosis state. Mm-hmm. That's well documented.
Next up, we get an opportunity to preview a trailer for a new documentary called Honorable But Broken, EMS in Crisis. It's going to be narrated by Sarah Jessica Parker and spends time talking about the level of crisis that we have in EMS system here in the U.S. because if we were to make EMS an essential service, it would mean that we have consistent funding from local, state, federal governments. And with this kind of reliable funding, EMS agencies could hire more personnel, reduce response times, and provide better training. So it's especially important in rural areas where resources are often scarce. And that's why we need to ensure the stability and effectiveness of EMS. It's a change that could make a real difference to improve health outcomes across our country. And so I worry about ambulance deserts, especially now. There's been quite a bit of talk about it in the media. Byron E. Gilby is a producer who I'm going to interview in the next show, and she does a documentary production that is awesome and hits what we really need in EMS right now. So I'd like to play the trailer for you today of her new documentary, and then look forward to next week interviewing her for the show.
I worked in New York City in spring of 2020, and we were pretty hard hit. It was kind of like a 9/11 every day.
It was so bleak during that time, seeing the cries and screams of people, seeing the disparity that I'm the one working on the road, no one else is on the road, and I'm taking people to the hospital, and that may be the last time they're interacting with that family member or their loved one. It got to a point where I broke.
You can freak out like in the ambulance, and then when we're inside, then we're like calm and collected because we have to reassure them that we're there to help them, and then that we know what we're doing. And even if like inside we're like, oh my God.
When the pandemic hit, many people worked from home. That wasn't an opportunity that 911 EMS was afforded.
They're the third uniformed service. Their job is as dangerous as police and fire. They have been right up in the front lines taking care of very sick COVID patients, constantly exposed to infectious disease.
We met people who have been in it for a lifetime, and they've never seen it more sort of broken than it is now.
I think many people assume incorrectly that EMS is considered this quote-unquote essential service. And unfortunately, in many of the legislative frameworks, EMS was just left out.
One of the biggest challenges with EMS, the way that it is structured today, is the funding mechanism, the economic model.
All across this country, EMS agencies can't recruit, retain, and staff ambulances to a point to ensure the public safety.
One of the biggest disservices that I believe as a very high productive and financially sound country is when we can't take care of our own.
I believe our rural areas are the alarm sounding. We want people to know that this is a crisis that they need to pay attention to.
Particularly rural areas don't have the required EMS coverage. When someone calls 911, there's no assurance that they can get an ambulance.
People always want to talk about the cost of responding to the call, whereas we should be talking about the cost of readiness to respond to the call.
We need to have full-time paid personnel at adequate salaries who have chosen this As a profession, this is a noble profession.
As an EMS worker, it's very difficult to live off of one salary. Therefore, I have to work at several different agencies just to pay my bills.
EMS has not been considered and viewed as a required essential services for the what-ifs. And is that, as a society, something that we are willing to fund and pay for? That's where it starts.
All we're doing with essential services is saying that this is a critical piece of public safety, much like fire and police, and that we want a bill to be able to make sure that this essential service gets funded appropriately and it can deliver the service that the public expects.
It doesn't translate into money per se under state law to simply call something an essential service. We have to rebuild the EMS system from the ground up to create a system that has enough money to sustain itself.
I'm doing a research project related to paramedics who live in the United States, and I could use your help if you don't mind being interviewed for an hour. If you do, go to my website and fill out a form at www.professorbram, that's BRAM.com. And thank you again for listening. I look forward to sharing more insights with you in this next episode. If you enjoyed EMS research, please tell your friends and like, share, and subscribe so that others get the message too. Hang on, and we'll get to the references from everything I covered in the podcast today.